Hi everyone, it's me. Welcome to our latest journal club. I am just waiting for Dr. Mark S. Komrad to join me. We're just starting a few minutes early, and we'll start the actual talk at 7:30. But just wanted to get on the video and make sure all the technical stuff is working. Oh, there he is already. Great. Let me add him. Okay. And let's see. It just says adding right now, so I'm just watching that.
Can you see me?
Yeah. Hello.
Yeah. Hello.
Hey, hi, hello. Very good. How's the?
Do you have earphones
Do
in?
you have earphones in?
No, should I?
Yes.
Yes.
Okay. I'm not having any problem with the sound. Are you having problems?
Yeah, it's echoing.
Yeah, it's echoing
on my end.
Okay.
on my end.
All right. Let's see here. Trying. One of the problems is it's difficult to prop this up.
Yeah.
With the
on
the iPhone with
Well, the sound is better now all of a sudden,
this
but
thing in here because it's at the bottom of the. Here we go. All right. Let's see.
hey guys, if you're just joining us, we are just starting a couple minutes early. We'll still start the actual talk at 7:30, but wanted to just kind of get on the video and make sure all the technical aspects are in place. So, you've got your earphones in?
Yep, I do.
Okay, sounds
Good. How
sounds
does it?
good.
How does it sound?
Very good. Yeah, perfect.
Okay,
Thank you.
great,
And
great.
thank you so much for joining me tonight. We're just going to wait a few minutes before we get started, but how's everything on your end?
All right, everything's good on my end. So I can keep everything arrayed on the desk and look at my notes.
Yeah.
But I think I'm good. As long as you can hear me and see me, I think that's fine. And how's the lighting?
Wonderful. Really bright, actually. It looks good.
Should I? Is it too bright?
Yeah,
There
that
we
looks a little bit. Yeah, that looks good. So,
Okay.
hey guys, if you're just joining us, we're just chatting for a couple minutes until we get started. And are you in New York, Mark?
I'm in Baltimore.
In Baltimore, that's right.
Baltimore.
Okay, got it. Okay, and I'm in Chicago, so in different time zones.
okay.
Yeah.
Right,
But
right.
and you'll be at the APA, correct? I saw on one
I'll
of
be
your
at the
posts.
APA, and as a matter of fact, I will be debating this issue with David
Yeah.
Pollack from the University of Oregon.
Okay.
We will. The title of the debate is "Assisted Suicide or Assisted Dying," a debate.
Oh wow. Okay.
And we'll be going head to head, a presidential-style debate where the moderator throws out
Yeah.
questions
Oh,
to each
wonderful.
side.
And so, does that mean that each of you has different opinions about the topic, or were you kind of just assigned to?
No, we both have very strong opinions on opposite sides of the
I
topic.
see. Oh, that
So
should be really interesting.
we were deliberately chosen for
Okay.
the passion of our opinions. And
And
each of us, in our own way, has been somewhat of an activist on the two sides of the equation.
Interesting.
So they
Okay.
wanted to create maximal drama.
Yeah, it sounds like it. And so, what day and time is that talk going to be?
So that talk is going to be on Monday at, let me just check. I think it's, let me look for it. I'm pretty sure that it's Monday
Sometime
at
on
1
Monday.
o'clock.
Okay.
Let me give you the exact, I have the exact information here.
Yeah.
So it will be Monday at 1 o'clock in room 23 on the exhibition level of Moscone
Okay.
North.
Oh, wonderful. Yeah. So I'm going to be at the APA also, so I'll try to make it. So.
Good, good.
Yeah, and thanks everybody. It looks like we have a little bit of a crowd. We've got a few people watching. If you want, say hi, and I'll be kind of acknowledging everyone on the through texting. And what we're going to do is I'm just going to read Dr. Comrad's bio in just a moment, and we'll get started. So I'm sure many of you know he's one of our active members on Psychiatry Network. Always look forward to reading his posts and his opinions. And he is an ethicist and quite an expert in this topic. You know, I've been trying to, as much as possible for our journal articles, get people who are really knowledgeable in the area that they're talking about. So Thank you to Dr. Komrad, and let me read his bio right now so you guys kind of know a little bit about his background. Mark Komrad, MD, is a practicing psychiatrist and medical ethicist for over 30 years. He chaired the ethics committee for Shepherd Pratt Health Systems, the largest nonprofit mental health system in Maryland, for 2 decades. He is a clinical professor of psychiatry at Johns Hopkins, the University of Maryland, and Tulane. He's lectured, taught, and consulted in the US and internationally on topics in psychiatric ethics and published numerous articles in the field. He's a member of the APA Assembly and previously served 6 years on the APA Ethics Committee. In these 2 capacities, he helped craft and pass the new APA position statement finalized in December 2016. And the statement states that a psychiatrist should not prescribe or administer any intervention to a non-terminally ill person for the purpose of causing death. He's now lecturing widely throughout the US, Canada, Scandinavia, South America, and Europe to address the ethical concerns that several hundred suicidal psychiatric patients in Belgium and the Netherlands are being voluntarily euthanized each year with lethal injections, typically by their own treating psychiatrists. He's consulted to policymakers in several countries trying to dissuade them from legalizing assisted suicide and euthanasia, or to prevent extending existing laws to include psychiatric conditions. Dr. Komrad maintains a private practice and has a special interest in helping families convince a troubled loved one to get a psychiatric consultation using ideas from his book, You Need Help, a step-by-step plan to convince a loved one to get counseling, which you can find at youneedhelpbook.com. He gives workshops on these ideas to mental health advocacy and support organizations throughout the country. And for this work, he was given the National Alliance on Mental Illnesses Exemplary Psychiatrist Award and Mental Health Professional of the Year Award. He was also host of the national radio call-in talk show about psychiatry called Komrad on Call, which broadcasts to 43 million listeners throughout the US and continues to appear regularly on TV, radio, and podcasts to discuss topics in psychiatry. He's also consulted to Hollywood to help develop more ethical portrayals of psychiatrists in the movies. So that is a wonderful bio and really tells us a lot about your work in this area. So thank you again for joining us, and feel free to take it away.
All right, thanks so much. Well, I very much appreciate the invitation, and it's very nice to say hello to all of the people that I've been connecting with and corresponding with, or have been lurking out there on the list.
Yeah.
This is a very nice opportunity to have another dimension to that experience. With regard to this particular topic, I appreciate an opportunity to talk about it. This is something which, as you've heard, I've so immersed myself in this particular topic in the last couple of years that in fact it's really become almost an additional part-time career for me. And many people actually have observed that this particular issue, which I consider to be the single most important issue that has come to me in my 35-year career as a psychiatrist and ethicist, is gradually transforming me from an ethicist into an activist. Simply because my own particular understanding of what's going on with regard to physicians now having increasing opportunities to take the lives of their patients, particularly psychiatrists, is an inversion of all that I've come to learn as the fundamentals of what it means to be a physician, but particularly a psychiatrist. And I've been paying a special attention to the issue of psychiatric euthanasia that we're going to cover a little bit in this paper. So let's dive in, because there's a lot of ground to cover. And what I'd like to do is I will review the paper, and as we go through the paper, I will try to supplement the paper with additional information, particularly information that has occurred subsequent to this paper, because this paper was published in July of 2016. And there's been a tremendous acceleration of developments in this area that I've been keeping an eye on. So I'll let you know when I'm giving you information that's really supplementary or an enhancement to the paper.
Great.
Because I think it's important that you be brought up to date. So our paper today is Zeki Emanuel's paper on the attitudes and practices of euthanasia and physician-assisted suicide in the United States, Canada, and Europe. Just a couple points, an overview about this paper. One is that it's limited to the fact that it was published in mid-2016. As I said, there have been many developments since then, particularly in Canada, which was just gearing up when this paper was published. Secondly, he kind of minimizes attention to something that I think would be of particular interest to this audience, which is what's going on with psychiatric patients and the involvement of psychiatrists. Those are some of the limitations of the paper that, as I said, I'm going to try to supplement. So he covers in this, he mentions in this, that some form of physicians helping to patients to end their lives actively is now available in the United States, Canada, Belgium, the Netherlands, Luxembourg, Switzerland, and Colombia. He starts off by looking at the United States. When this paper was published, there were only 6 jurisdictions that allowed something called physician-assisted suicide. We're going to define our term shortly, as he does. When this paper was published, Oregon, Washington, Montana, Vermont, California, and Colorado were all legalized. However, since 2016, there's been a 50% increase in those 6, and District of Columbia, Hawaii, and New Jersey have come online with laws legalizing assisted suicide. New Jersey just a couple of weeks ago, as a matter of fact. But I do want to add that, in fact, it has been rejected far more times than it's been passed. Since 1998, it has come up 275 times and has been voted down and rejected. As a matter of fact, in the last year, 2018 through 2019, it's been rejected in 18 states. And as a matter of fact, there are 9 states that have gone so far as to create inoculation laws in one form or another, where they said, we in advance are saying as a legislature, we do not want such a law in this state. It's really very unusual to introduce inoculation laws like that. So that's an interesting development, primarily in the last several years. All right, now let's talk about definitions. The definitions that he reviews in the paper. There are kind of 3 fundamental approaches here. One, which is the ethical status quo, which is passive euthanasia. That actually is something that really is ethically normative and has been for quite some time, which is simply allowing a patient to refuse treatment. And of course, it's a little bit tricky when we come to refusing psychiatric treatment, but in general, competent patients have long been allowed to refuse treatment, including refusing life-saving treatment, especially the right to allow treatment to be withdrawn. That term of art is called passive euthanasia. It's often accompanied by palliative care or not palliative care as a way, particularly for terminally ill people, to allow them to be comfortable in the setting of refusing treatment. The second term is assisted suicide. Assisted suicide is where a physician, or in Canada, nurse practitioners and some other professionals, are allowed to write a prescription for the purpose of causing death. Typically, it's a box of barbiturates that the patient has to take, numerous pills over a long period of time that's dispensed to the patient to take at the time and place of their own choosing, and without necessarily tracking what happens to these boxes of barbs. They may very well get stored in the closet. Hopefully your suicidal granddaughter doesn't get to it first. But that is assisted suicide, and assisted suicide is the only, in those jurisdictions that we listed in the United States, that's the only practice that's allowed, and it's allowed, as we'll see in a moment, just for those with terminal illness. The third term of art is euthanasia. Euthanasia refers to the administration of a lethal injection. A physician starts an IV, pushes the IV, and produces death within a matter of minutes, just like a lethal execution. In all the countries that we're talking about today, that is the predominant method. And although assisted suicide is allowed in countries outside the US, they also allow euthanasia, and the findings have been that given a choice, if you permit both of those things, patients far and away will prefer euthanasia. And so 99% of physician-terminated life outside the United States is done by euthanasia, but not in the United States. By the way, you can also see that there's tremendous sort of who owns the language is very important in this. And so one tussle is over whether to call assisted suicide or assisted dying. And in fact, how you phrase that can very much affect opinions, much like the debate on abortion, choice versus right to life. Now, he reviews the history for us and notes that in Switzerland, since 1942, that some form of this has been allowed. It's really that anybody who helps another person to commit suicide or provides a means for a person to end their life is considered legal in Switzerland as long as there is no selfish motive. That's the Swiss law. So it's very loose there. There are a number of private clinics that have this available. Switzerland is really the only country that provides suicide tourism. You may have read about some cases of people going over to Switzerland to be able to terminate their life in one of the Dignitas clinics there. And that system of independent clinics has really been stood up particularly since 1988. In the Benelux countries, Belgium, Netherlands, and Luxembourg, they have allowed euthanasia since 2002. And they've taken a unique approach to euthanasia, which we'll get to shortly in another section. In the United States, Oregon was the first state that allowed physician-assisted suicide. And then subsequently the 7 other jurisdictions that we spoke about. And remember that the United States, it's strictly assisted suicide, not euthanasia, and it's strictly for people who have terminal illness. Canada developed a federal law permitting euthanasia just the month before this patient was published. So he doesn't have much information about it. We'll get to Canada in a bit, and I'll fill you in. But in June of 2016, their so-called C-14 law was passed federalizing euthanasia or assisted suicide, but it's as often the case when both are offered, it's mostly euthanasia there. Also, Colombia and Australia are mentioned in the paper. We don't really have time to go into those. Australia sort of experimented with it while pulled back from it. We don't have that much information about what's going on in Colombia. All right, the next thing he wants to tell us about are some of the parameters of eligibility. So first is age. In the United States, you must be at least 18 years of age. In the Netherlands, they will accept potential candidates for euthanasia as young as 12. But in Belgium, as of 4 years ago, they took away all lower age limits. But the difference is unlike adults, children under age 18 must have a terminal illness in Belgium, whereas you don't have to have a terminal illness, as we will shortly discuss in Belgium. And Canada also has a lower age limit of 18. They've recently been debating with a special study group from a variety of institutions as to whether they should open it up to children. And that study group has recommended caution. But we are expecting a new Liberal government in Canada shortly to possibly allow breaking the 18 age barrier. All right, so now he wants to talk about, in the paper he discusses some of the criteria in different countries for these procedures. So in the United States, the criteria is strictly terminal illness, which means that death has to be expected without treatment within 6 months. It's a little bit variable from state to state. It's one of the problems, is that some of these definitions vary as well as the procedures. That he really doesn't discuss in the paper is some additional features of laws in the states that allow this. One is no state requires any mandatory mental health assessment or treatment with the exception of Hawaii. Hawaii, every case who applies must be reviewed by a mental health professional, but it doesn't have to be a psychiatrist, it could be a social worker. In fact, it can even be an alcohol counselor. The purpose of the review is to determine capacity, which is interesting since actually most psychiatrists aren't even trained to determine capacity. It tends to be a forensic specialty, but any of these mental health professionals can determine capacity and rule out mental illness. But except for Hawaii and all other states, psychiatric assessment is not required. There's no requirement for those physicians that are evaluating patients, and typically it takes two, a first opinion, which is typically the treating physician, and a second opinion. There is no requirement for any specialized training in mental health or any specialized training in capacity assessment. In all these states, any physician can act as a second opinion, even if it's your partner in your same practice. So it doesn't have to be, scrupulously independent. In none of these states is there any requirement that palliative care be attempted, because again, the right to refuse treatment is accepted by the patient. As a matter of fact, in none of these states is it even required that a patient accept any kind of life-saving treatment. So if you want to turn down, for example, renal dialysis, you can certainly turn down renal dialysis or chemotherapy. Interestingly, also the law says nothing about whether about a person who converts themselves to terminally ill. So a well, stable, maintained diabetic who chooses to stop their insulin can create a situation in which they become terminally ill and they are legally eligible. Now you say it may not be ethical for a physician to provide it under those circumstances, but ethics aside, and we know that you can't count 100% on the ethics of any profession, but if it is certainly legally possible. No witnesses are required to verify when people take their box of barbs that there isn't coercion. Heirs who may benefit from a person's death are allowed to sign family consent forms in those jurisdictions that have consent forms. There's no statutory definitions of how to distinguish the difference between encouragement and coercion, or support and coercion. There is no minimum length of time required for a doctor-patient relationship. Doctor shopping is allowed in all of these jurisdictions. In no state that has physician-assisted suicide can suicide or assisted suicide be listed on the death certificate. The death certificate must say the cause of death is the underlying illness that created the terminal condition. And in no state are the lethal box of barbs that are dispensed allowed to be tracked. So we have no idea what happens in the states that have been at this for a while, Washington and Oregon. Approximately 1/3 of these boxes of lethal medications go unused. And we have no idea what happens. There's no recall on them and so forth. So those are aspects of some of the laws in the United States. Now going over to Benelux, Belgium, Netherlands, and Luxembourg, they did something very interesting in 2002. They got out of the business of terminal as a criteria. They took away the distinction between terminal and non-terminal illnesses, and they took away the distinction, a very distinction that we have actually been championing as psychiatrists, between physical and mental suffering. They say suffering is suffering is suffering. Their criteria is that a condition must be untreatable and insufferable. So the patient has to not be able to bear it, and there has to be no substantial treatment options available that are acceptable to the patient. Again, the ethical status quo of the right to refuse treatment remains intact. So if you want to offer a patient a treatment, let's say in psychiatry, ECT, and the patient says, no, thank you, I don't want ECT. If that's all you got, I guess I'm untreatable, that's okay. So it's no longer about terminal or non-terminal, it's about untreatable and unbearable. That opened up euthanasia to psychiatric patients. And this is actually something the paper doesn't get a lot into, and we'll talk about this shortly. It gets into it a little bit. But since 2002, the number of patients with just psychiatric illnesses who have been euthanized, often by their own treating psychiatrist, the same psychiatrist who used to be trying to prevent their suicide, are now actually able to provide it. Going to Canada, Canada in 2016 passed their federal law. They came up with their own unique definition, which is death in the reasonably foreseeable future. It's not necessarily terminal. Nobody's entirely sure what it means. The next section he looks at are public attitudes to this. What's interesting, I actually very much admired his criticism of using polls to decide this. And he actually gets into the whole issue of how the questions are framed, because how you ask the question, how you word it, significantly affects how people respond to polls. So first he talks about the public polls, and he notes typically these polls have a very low response rate. They typically are responded to by those who are passionate about the issue on one side or the other. He actually has some interesting examples in Table 3 of how the questions are framed. It's interesting, if you use the word suicide, assisted suicide, or anywhere in any of the questions, the endorsement rate by the general public really drops compared to if you leave out the word suicide. In the United States, the public endorsement of this is correlated with being white, having a higher socioeconomic class, being more educated, being Christian, particularly Protestant, not Catholic. He says that through 2012, support has been dropping in the public, but in fact, since 2012, that's turned around. And especially in the last several years, it's been rising, which with as much as 79% of the United States public now favoring legalization of assisted suicide in the Benelux countries. And he talks about physicians. He notes, again, problems with the polls. Physicians in general have a much lower rate of support from the public, perhaps not surprising, especially as we're the ones who actually have to do the killing. When you do rigorous studies that are very carefully done, it actually shows the minority of physicians tend to support this. We, doctors, much prefer assisted suicide compared to the public, who prefers euthanasia, because a patient would rather outsource this as a medical procedure to a physician to do the deed for them, whereas we'd rather outsource it to the patient to give them a box of barbs and have them disappear and take it at the time and place of their own choosing. So then he gets into actual practice. So some of this is old data, and in fact, some of his U.S. participation results are a little old to review. I want to supplement that with some of the latest results from Oregon. In Oregon, about 1% of physicians last year in 2018 wrote for assisted suicide. 3 doctors wrote 20% of all the prescriptions. 1 doctor wrote 89 scripts. And several physicians have collapsed their practice or come out of retirement, and all they do is evaluate patients for assisted suicide and write those prescriptions. Through 2015, if you combine Oregon and Washington, the 2 oldest states that have been doing this, there are over 1,600 deaths attributable to assisted suicide. About 75% of them were for cancer, 15% for neurodegenerative diseases. Patients are always asked, what are the most important reasons why you want this? And consistently in those 2 states, 2 out of every 3 patients cite fear of loss of autonomy, fear of loss of dignity, fear of dependency on other people, not pain. Fear, anxiety, which, by the way, happens to be something in the wheelhouse of psychiatry, and yet no psychiatric evaluation is required. In the Netherlands, there are 2 different routes. One route is you can have it, euthanasia by your own doctor, but they've also, if your doctor is squeamish about it or maybe even disagrees with it, there's a system of clinics there called the Levenseinde clinics, end-of-life clinics, which, by the way, is where about 75% of all the psychiatric euthanasias are done. People end up in these clinics. 60% of all physicians in the Netherlands have provided euthanasia at least once. And in more recent data, 2017, almost 5% of all human beings who die in the Netherlands die by physician euthanasia. 5 out of every 100 human beings, which, by the way, is slightly down this year. They kind of backed down a little this year. We can talk if you'd like about that. In Belgium, about 2% of all human beings who die in Belgium die by euthanasia, although in the Flanders region of Belgium, over 6% of people die by euthanasia, which is even higher than the Netherlands. And remember, in these countries, psychiatric patients are allowed. About a little over 1% of all euthanasias are psych-only cases. In 2016, there were 77 psychiatric patients euthanized in Belgium. In the Netherlands, in 2017, there were 83. And in 2018, a little bit fewer, 67. But that's non-dementia. Those are schizophrenia, bipolar disorder, ADHD. I mean, it's really remarkable. Complicated grief. 50% of these patients have borderline personality disorder, which is perhaps not a surprise. Now, with regard to next section is about evaluating the practices. So he says that in most places there's respect for a waiting period. In Oregon, for example, there's supposed to be a 2-week waiting period between the patient's request and the ultimate provision of the prescriptions. Although there was at least one case in 2018 that was as short as 4 days. So this respect for the waiting period really is not consistent. He looked at whether or not hospice and palliative care are being short-circuited by this. In Oregon, 13% of patients have never had any hospice or palliative care prior to being granted their box of barbs. And in Washington, 19% has never had palliative care. In the Netherlands, 26% of patients go right for the euthanasia without palliative care. In terms of optional, if the attending physician think maybe we have a capacity issue or maybe we have a mental illness. In 2018, in Oregon, only 1% of patients were actually referred for a psychiatric evaluation. In Oregon, there have been many complications of trying to give this large number of barbiturate pills to people. In about 50% of cases, regurgitation, awakening, prolonged dying. There was one case that took up to 7 days. He talks about his concerns in places that have been at this for a while, particularly in the Benelux countries, what he calls routinization. You know, the more you do this, the easier it becomes, the more normal it becomes, and it becomes more and more difficult to contain the criteria to a circumscribed set of patients. So some of the ways that we've seen that the effects of routinization is support by professional societies, the medical society, the psychiatric society over in Europe all have brochures about how to kill your patient, following the law, and how to properly prescribe and how to give injections. There's now in Canada, the Royal Canadian Medical Society has endorsed this as an acceptable practice. We can talk about a curious development in Canada regarding conscientious objection if we have time. There is a slippery slope. There in Europe, that's been at this for 18 years. There's a fairly large number of administration without consent. In the Flanders region alone, there's 26% of cases that have not followed the criteria set out by the law. In about 2% of cases in 2013, it was not clear that the patients consented to this. Some of them were given proxy consent by their guardians, but many of them, they couldn't track down any family members, so the doctors took it to their own hands and decided for the patient that this was a life not worth living. He talks about really a remarkable development in the Netherlands, and even in Belgium is going in this direction. First, it started with the terminally ill, then it went to the non-terminally ill, then we developed psychiatric patients, then people with difficult lifestyles such as ego-dystonic homosexuality and unsatisfactory results from gender reassignment surgery. And now there's considerable discussion, especially in the Netherlands, that they should demedicalize euthanasia entirely and not have it limited to any kind of a medical condition that's insufferable and untreatable, but it should be available for people who claim they're tired of life or they've completed their life. This is being supported, as a matter of fact, by a retired Supreme Court justice there and a large grassroots organization called the Dutch Voluntary Euthanasia Society and the Minister of Justice and the Minister of Health in the Netherlands and the head of one of the leading political parties, the D66 party. They're all pushing for tired of life as a criteria or completed life, and they're trying to push for the development of an over-the-counter suicide pill that patients can just go and take without even necessarily having to knock on the door of the House of Medicine. He talks about suggestions that he'd like to see for additional research. He thinks that we need more studies to look at the influence of how legalizing these practices affect society in general, how it changes the fulcrum between acceptable and unacceptable suicide, how it might lead to suicide contagion. There's actually some interesting evidence to point in that direction. How it affects the whole idea that there may be lives not worth living, could possibly affect vulnerable groups, the disabled, or affect the trust of physicians. And he's very concerned that most of the laws in the United States are full of loopholes, and that especially the reporting that would allow for research is really not adequately provided for. For example, you can't say assisted suicide on a death certificate, and it's voluntary for doctors to report that they've dispensed this. And we're beginning to see that not all physicians are scrupulous about that reporting. So that's an overview of the paper and filling in some of the areas that he didn't cover. Do we have time for questions?
We do have time for questions. If anybody has any questions, please post them now. Let me see if there's any. I don't see any. Well, there may be some. I don't see any questions so far. I've been kind of watching the threads. So sometimes people will post questions after the video's over, like over the next 24 hours. And if so, we'll see if I'll tag Dr. Komrad and see if he can answer them. That
Do
was
we have time
really
for me to add a couple of additional while we're waiting?
Oh, sure.
So I want to just add a couple of interesting additional things that weren't covered in the paper. One is that in the province of Ontario in Canada, both the medical, College of Ontario College of Physicians and Surgeons has declared it unethical, and the courts have agreed it is illegal to practice complete conscientious objection. They say that you must, even if you don't want to provide euthanasia, if a patient comes to you and asks you to consider euthanasia, you are ethically obligated, if you don't want to participate, even in doing the evaluation, to find them a doctor who would be willing to consider it. So you have to be part of the chain of referral, or else you're an unethical physician and your license may be in jeopardy. So that's interesting. One of the things that I've learned is there are actually 5 countries that have a similar law about abortion, where if in the first 18 weeks, if you're capable of providing abortion and you refuse to do it, your license is in jeopardy. So it's the same kind of approach that they've now taken with euthanasia in the province of Ontario. Another interesting thing to know is that countries that have been doing this are linking organ donation to euthanasia, a virtue opportunity. that as long as you're getting euthanized, you might have an opportunity to give the gift of life to somebody else.
Oh, wow.
And in fact, in Canada now, there is increasing discussion about euthanasia by organ donation, namely, we will perform your euthanasia under the same anesthesia that we will give you in order to harvest your organ. And of course, if you think about it, and you think about the jurisdictions in Europe that allow psychiatric euthanasia, who are the most have the most desirable organs for transplant? It's young psychiatric patients. You know, most of the psychiatric patients who are euthanized are in their 20s and 30s. So this Dutch Voluntary Euthanasia Society that I mentioned before, they put on a festival, a week of euthanasia every year, and it's marketed towards young people to encourage them to come and get their head around political activism for euthanasia, lowering the criteria and having the over-the-counter suicide pill and having a completed life and end of living. And it turns out a lot of the people who show up, the majority of people who show up to this are young psychiatric patients who, although they know that euthanasia is eligible for psychiatric patients, they feel the criteria are way too strict. At this week of euthanasia, one of the workshops is the virtue opportunity of donating your organs. So, you know, there are all sorts of remarkable implicit and explicit coercions and seductions. So, you know, what happens to a society that has kind of gone down the rails here and which has elevated autonomy and self-determination as sort of the new sacred standard that may replace more old world values like sanctity of life and so forth? We're beginning to see in the living laboratories of Europe some remarkable developments.
Yeah, I kind of wonder a little bit too about psychiatrists who are just having a hard time with treating a particular patient. If this is just might be a little bit easier so that I don't have to continue,
you know, not just psychiatrists.
Even.
I mean, right. I mean, look, we know about countertransference, right? And we know about the phenomena of projective identification, where patients can inject the treater with their hopelessness. Exhausted treaters, exhausted families, exhausted healthcare. You know, I have, you know, how many of us who've been in practice for a while with chronic suicidal patients who either with their ideation or their attempts and their revolving door hospitalizations haven't felt the exhaustion. And of course, we in psychiatry are kind of, at least have some training and some reflectiveness about this phenomenon. But if you think about non-psychiatric physicians who really are not prepared to even examine that. So there was one study that looked at the role of countertransference in euthanasia decisions in Belgium. And an independent study felt that in 24% of the cases that they looked at, they felt the primary driving issue were countertransference issues in the referring physician.
Oh gosh.
As what the primary reason that physicians were supportive of the euthanasia, referring for euthanasia, providing the euthanasia, and in this independent review, they felt that that was a false flag, that, you know, that was not, these patients were actually not appropriately eligible for euthanasia, but it was too late, they had already been euthanized.
Very interesting. Oh my gosh, what a complex issue.
Right.
Yeah. Thank you so much for putting all that together, synthesizing that information, and adding the additional info from the last couple of years. So.
Sure. Yeah. I'll be happy to field questions that come up over the next several weeks as people.
Oh, wonderful.
I guess this is available on recording.
It is, yeah. So it'll be available in the group and on the American Physician Institute website. Once you watch the video, you can answer the 3 CME questions and earn free CME for doing that. And just as a reminder, you guys, if you haven't signed up for the mailing list, just email me at psychiatrynetwork@gmail.com and you can get added. All right.
Can you just remind us of the web address of the American Physicians Institute?
Yeah, I actually have it in the link up at the top of this post in particular. So it's just up at the top. Yeah, you can just click on it directly. And if you don't have an account, set up an account, which is free. And this course it's basically the whole course of all the videos that we're doing, which is 42 by the end of end of this month. So,
Great.
all right. Well, thank you again to Dr.
Thank you
Komrad,
all.
and yeah, thanks everybody for watching. And we'll see you guys on Wednesday night. Okay, take
Appreciate it.
care. Bye.
Bye-bye.